about us. Think about you leaving.
Hello, we are live. We're sorry. This took me forever. Sorry, Instagram. We are figuring out how to. Do we look okay? How's everybody doing? I see D. Lynn, DPC. What's up, Roel? Can you guys see me? Do I look okay? We got a little bit of a different screen. Hey, will you check what it looks like on when you're up there, and just shoot me a message with how it's looking? What's up, Instagram? We're gonna be answering questions for you guys as well. Tom, how do I look, man? Do I look okay? It's a weird screen. On my end, it looks a little bit different. All right, Linda, thank you. It's small. Yeah, I don't know why it's small. I can't figure that out. I'm trying to figure out why it did this, but it did it, and that's okay. That's okay. We're gonna rock it. Yeah, I feel reduced as well, Wayne. I feel reduced also. I'm going to try to figure this out as we're waiting on Dad. I have no clue why it's doing this. Layouts. No, didn't work. The audio is good. Okay. Ivy, what's up? Happy Thai Tuesday to you. I'm actually going to have some Thai tonight. Funny you say that. It's Taco Tuesday or Thai Tuesday, however you guys, whatever's your preference. If you guys got questions, go ahead and put them in the comments. We had a great question come in throughout the week. Just one though. So we're going to spend most of our time live. I see you guys on Instagram. Thank you all for hanging out down there. Rick, what's up? Rick, what's up, man? Great to see you. All right, we're going to get to all your questions. Grandma Mary, I love you. I'm in Kingsport. This is nice, Thai Noodle Town. All right. All right. Did anybody check out the biohack video by chance? Anybody check out, if I can find it, anybody check out this? This was Doc's My Personal Biohacks for Longevity. Super, super cool video where Doc just goes over everything he does. You guys have asked it on the show. It's actually a big reason we did that was to answer that question. So if you guys had a question with something that he's taken, what's up, Doc? Hey. Check out that video. And if y'all have questions for Doc around that episode, ask now. We'll be here all night. Well, actually not all night. I haven't even eaten yet. So we can't do all night.
Let's do 1 hour.
We can't. Okay. We're going to do 1 hour. And we'll be here with you guys. Instagram. This is, there's Dad. What's up? There's a little behind the scenes. So we're everywhere. Edna, what's up? Edna, keep us posted with how PRP is going. I know it takes a while to to kind of feel the effect, but keep us posted.
It took me about 2 months.
2 months for yours?
Yeah. For my knees
and
shoulder.
You were talking to Andy, and I think he's getting his in his elbow?
Tomorrow, shoulder.
Shoulder tomorrow? Yeah. And you've gotten yours in like your thumb?
I had it in my thumb. It didn't work great for my thumb, but it worked great for my knees and my shoulder. But it took a while.
Where's your mic? Oh, there's your mic.
Oh, this is my mic.
For you guys who don't know, Mama Bear, how do we look? No, you're looking at a different version. We do a podcast too. So this is on the podcast. Okay, so it's been 3 weeks, Edna. All right, now we're live. Now we're recording on the podcast. Okay. Hello, man. This is fun. Like I know, like we normally do this remote.
Yeah, we do. This is fun.
Actually, you know what, guys? I'm at home right now. This is my dad, of course, and I hate to do this, but my mom's watching. Mom, do you mind putting my dinner in the fridge? And after the show, I'm gonna go up there and heat it up. How cool is
I
that?
just ate.
I haven't eaten yet.
Yeah, you're more dedicated than me. So
Mark,
we will feed
I don't
you.
know what the aspect is, and I don't know how this happened. So we're still trying to figure that out. Can you guys hang with us? Like, is this? Are you guys okay? Okay, thanks, Mom. We're gonna do the show like this. We want to get to as many questions as possible, and if Doc's ready to go, I'm ready to go.
Sure. Yeah.
Cool. All right, and Instagram, I got your questions as well. So if you guys have a question for Doc, go ahead and put it in the comments. We'll answer yours as well. And here we go. This came in throughout the week. Can you guys read that? What does Doc think about HGH? Who should take it? How much? How often? Long-term benefits, risk? It's a long question, but real quick, kind of give what is HGH?
Yeah, human growth hormone. Yeah, the only people that really should take are basically dwarfs, kids that are really short stature, and they're approved. A lot of adults would like to take it, but for one thing, it's illegal. We can't prescribe it.
In all states.
Yeah.
Okay.
As far as I know. Yeah. I mean,
okay.
You just can't do it legally unless, like I say, you meet the criteria. Now, there are a couple exclusions, like if you have panhypopituitarism, where you've had brain surgery and you don't have a pituitary that works. So I've gotten a few people through with that. But as far as just aging and all, you really can't do it, or bodybuilding, you just can't do it.
Mm.
But there is a way, kind of. Number one, you wouldn't want to do it. You couldn't afford it anyway. It costs you $1,500 a month. And the other thing, it can have side effects. Like suppose you had some occult tumor somewhere, it could make it grow faster. And it can also raise your blood sugars, cause carpal tunnel. And so it's just not worth it, really.
Yeah.
I know the bodybuilders like it, but they're taking a major risk, and a lot of them do take it illegally. But there is an alternative, something that I do myself. It's a peptide, like Samorlin. The one I like is CJC 1295 with ipamorelin, and that is more of a legal, completely legal, affordable. Doesn't have the side effects. It really just kind of it's like growth hormone releasing hormone. It enables your own pituitary to release its own growth hormone.
Okay.
And so that's one of those things that you'd be better off doing. Number one, you could probably afford it, and it's still going to, raise your levels of growth hormone, which really is more of a repair hormone. So, I mean, there's good things about growth hormone, but for the aforementioned reasons, you just can't go out and say, I think I'll take some HGH.
Right.
You just can't do it.
Is there a particular peptide you like so say somebody has heard about HGH and they're like, what is the safer legal version?
Samorlin,
So it'd be Samorlin. Okay.
Yeah, that one,
okay.
or really ipamorelin, one of those.
Okay.
Yeah, those are my favorites.
And by the way, guys, that was, I think, CJC 1295 with ipamorelin was on one of your list.
Yeah, I do take that one.
Okay.
Yeah. It's a shot you take subcutaneous at night, because that's when you want to boost your growth hormone. That's when it's naturally released, and you take it 5 days a week, not every day, because you can get tolerant to it. But I like it. I think it helps, aging people not hurt so much, recover, and it really works synergistically with testosterone.
And this is the
Ipamorelin or Samorlin.
Okay. Super cool.
Yeah.
Guys, if y'all have, again, we're kind of referring back to the article that we put out today, along with the adjacent podcast episode on the Common Sense MD on what Doc is personally doing to kind of biohack for longevity. It goes straight down to what's in his medical kit when he travels, on vacation or for work. So definitely check that out. And, I don't know if you can do this, but, maybe, you can have it up, and if you have questions, you can put them in the comments. I see Zach's in here. Zach, what's up, brother? Great to see you, man. Zach's our editor, our video aficionado, we like to call him. All the stuff you see on Facebook, Instagram, TikTok, everywhere, that is all Zach. Zach, we appreciate you. We love you, brother. Okay, we're going to get to questions here. If y'all have a question, go ahead and put it in the comments. That was the only question we got throughout the week. If I missed your question, I have my eye on my email as well. You can put it in there, and I'll put that up as well. Okay, let's see where we're at. Tom, I love this. I guess maybe.
Which one, you or me?
I think me. I think me is because we're in a smaller frame.
Yeah. Okay. That's
okay, let's see. Thank you. Where's my questions at? Okay, let's go to Wayne. Wayne, what's up, man? What other hormones do you check for in men besides T? Great question.
Oh, yeah, that's a great question. I certainly check estradiol levels on all men. And I find it's odd. Some of them, they have their levels of estradiol are higher than their wife's. So that's why they can get gynecomastia and, cry at movies and get emotional. I'm exaggerating that a little bit, but it's certainly important. And really, it's not great for your prostate to have a really high estrogen level. But so, I check DHEA, I check insulin, cortisol, vitamin D is a hormone. I check a complete thyroid panel. And I look at all the inflammatory markers as well, which is very important. But that's a great question.
Yeah.
Those are the main ones I check. Sometimes I dig a little bit deeper. Sometimes I check an IGF-1, which is a marker for what your growth hormone levels are. It's worthless to check a growth hormone blood level because it changes so rapidly. It means nothing. But an IGF-1 is more of a longer term marker for your levels of growth hormone.
There's a lot, and I think that's one thing that we talk a lot about. It's not just testosterone.
Yeah, prolactin's another one I check. Depending, if you have really low testosterone, that's important to check it. Luteinizing hormone, follicle stimulating hormone. A lot of it depends on the workup. What age you're at, what I'm really looking for. So, I'll check everything on everybody.
Yeah.
For example, there's different forms of testosterone, different forms of estrogen. You can break it down into the three different types of estrogen. And of course, you check total and free testosterone, sex hormone binding globulin, things like that really give you a more full picture. So
it's a lot. It's a lot. I mean,
it can be a lot.
It can be complicated. Wayne, a lot of that's on the Cleveland Heart Panel, if you've heard us talk about that before. But I think the big thing here is there's a lot besides T. It's not just checking a testosterone
when
level.
you check your testosterone level, you really want to know why you have low T or suboptimal T if you do. If you're 70 years old, you know why you have low T. You're old. You're in andropause. So you don't have to do a very extensive workup as much. You try to keep it as simple as you can. But in a younger person, you really have to take a deep dive and see whether they have primary, secondary hypogonadism. It's even more complicated for women, of course.
Yeah.
Hormonally, women are much more complex than men. It's probably why we treat more women than men for hormones. Treat both. But
Wayne, thank you for that. And Max, I see you. I'll figure out. I'll put all those up. April, I see your question there. I'm going to get to that real quick for April, who is our regional manager in the Knoxville area. She's putting up liposomal artemisinin. Does it help with EBV?
Epstein-Barr virus.
Mm-hmm.
We use artemisinin for several reasons. Cancer, it's more of a natural, but I've seen some reports that it may be beneficial for it. That's a toughie to help. There's a lot of different things that can cause a flare of EBV. You talk about Lyme, you talk about mold. Sometimes I think it's all part of the same process of autoimmunity, but a lot of times it does have an infectious origination to it. So sometimes you do dig into that. It's just really difficult to say, hey, this is a cure for this.
Sure.
When it's a viral illness. And it's usually been going on for a long time. So you have to attack it with other things like low-dose naltrexone, methylene blue, some of the outside the box things. And then sometimes you can even, try doxycycline on it. I've done that at times, and try to tampen down that immune response. And certainly gut health, nutrition is all interplayed there. So that's what makes it so hard. And you have to work in different ways around it to try to help the overall health of the patient. I mean, it's not as simple as, here's your pill for EBV.
Right.
I wish it was, but it's just not.
Great question there, April. Thank you for putting that in. So Instagram, I see you guys. If y'all have a question, I hope you heard that. I can't quite figure out the visual part yet. Okay, let's get to, let's see, where am I at? Let's get to Nicole. Nicole is asking, what happened to the compounding pharmacy you used to use? We've used a number of different compounding pharmacies, Nicole. If you could give me a little
The one we used to use in Nashville, that's the one.
That could be it.
Unfortunately, the pharmacist died. Was in a car accident. And so they kind of shut down temporarily. I think they may have reopened under new ownership. I'm not sure. But we use a lot of different compounding pharmacies. And it might be, the tirzepatide, fortunately, we're still able to get it. They kind of reversed their decision on compounded tirzepatide. So for right now, it's still available. We're not going to do anything that's against the law, but with compounding pharmacies, they operate under a little separate set of rules than regular pharmacies like CVS or Walgreens. In that when they compound medicine, it has to be something you can't get from a regular pharmacy. They can't make it, or if there's a shortage like there are with semaglutide and tirzepatide, Ozempic and Mounjaro and that type of thing. But compounding pharmacies are really important. I've worked with them for many years, and if you go to any hospital and you look at their crash cart table, most of it's supplied by compounding pharmacists. You go to Mayo Clinic, their crash cart is supplied by a compounding pharmacy. So they're essential for our healthcare system. They make different variations of medicines. They can make them into creams, paste, things that kids can take. They also do a lot of veterinarian type stuff. So they're an essential part of our healthcare system. We would be really up the creek if they didn't step in and fill the gaps, so to speak. And they're all knowledgeable, and I'm sure there may be some out there that aren't, but the ones we deal with, certainly we vet them very well and get to know them. And believe me, I would not be afraid to take anything they compound. The ones we use myself, I certainly wouldn't use it on a patient if I wasn't willing to use it on myself. So,
I'm seeing Nicole's here saying for testosterone, it looks like Nicole gets at CVS now, and he feels it's different. Not sure. Do you have any thoughts?
Yeah, I mean, you should be fine giving testosterone cypionate at CVS. The enanthate's hard to get. We used to have the compounders make a blend of cypionate and enanthate, which was my favorite, but we just can't find it anymore. The enanthate's really hard to find. But he's fine, probably fine getting it at CVS.
Okay. Nicole, I hope that helps a little bit. I'm going to keep moving here and find my questions. Thank you guys so much for sticking with us live tonight. We go to Max on YouTube. I need Dr. Rogers' advice. I have low levels and need doctor's advice, who to talk to and what he thinks I should be doing. I have an oncologist appointment this Friday for iron infusion. Maybe she can be, hold on, let me see here. I want to make sure I go in order here. Max, let's see.
You're talking about low iron?
Max, let me know, because I'm seeing these levels.
Okay, yeah, really anemic.
I'm trying to find
it
the
looks like
question
an iron
here.
deficiency anemia, number one, you have to find out why you have an iron deficiency anemia. You know, you have some microscopic GI bleed, you have a polyp, you have an ulcer, is your bone marrow working? You're not absorbing the iron. What's your diet like? There's a lot more labs that need to be drawn besides the ones you're mentioning here. You need a ferritin level. You need a total iron binding capacity, maybe a reticulocyte count. So it gets complex when you sometimes we never find why, and sometimes, of course, the hematologists don't know either. So a lot of times, you know, if it's just an iron deficiency anemia without any other known cause, you're not bleeding somewhere that you don't know, and your bone marrow seems to be working, that, you know, sometimes we'll do a bone marrow aspirate to determine, you know, if those reticulocytes are working. But I agree, I would, if there's no obvious reason, you need to see a hematologist. But an iron infusion is certainly the fastest way to get it back up. Taking oral iron is a slow process. So I've seen quite a few patients for iron infusions in the past. So I wouldn't be hesitant to do it. You need to do it at a hematologist's office, though. And they do them every day. So find the cause. Look, I'm sure they're going to look at it on a deeper level, see what they say. And for right now, they're your go-to people.
Can you guys see the question? Because Max, we're putting I believe your levels up right now. At least I'm seeing that. Are you guys seeing the questions I'm putting up or not? It kind of feels like maybe you're not seeing. Okay, so you can see the question. Okay. All right. And
here's the other thing I would tell you, because I was reading something recently on this.
Yeah, I see you, Max.
You know, of course, that level of a hemoglobin, hematocrit's not a critical level. But if you got down, say, like a 7 on your hemoglobin, they wanted to give you a blood transfusion, unless you're actively bleeding, I would not get it, unless it was banked from your own self or maybe your family, because look at the crisis we had with AIDS, HIV, many years ago. I was, of course, practicing at the time, and saw several HIV patients, and the dogma at the time for blood donations was that they didn't need to be screened so much, and so that's part of that cognitive dissonance that people are so hard to change their mind, especially doctors. But they gave a lot of people HIV because they didn't have a way of screening for HIV. They finally figured it out, but they gave a lot of people HIV from blood transfusions, i.e. Arthur Ashe.
Yeah,
is the most,
that's right.
And Ryan White. So I don't know why I'm talking about this, but I was just reading something about it by Dr. McCarry at Johns Hopkins this past couple of weeks ago. I'm going to do a book review on blind spots in medicine.
Yes.
And he mentioned that ridiculous thing where they were taking these blood donations from HIV patients in San Francisco and just distributing it to people, you know, and infusing it to people. They gave many people HIV by that. Wow. They killed a lot of people doing this. So, you know, that's why if you get in the hospital and there's a, well, let's give him some blood. Don't do it unless it's your own blood or your banked family blood, unless you're critical. And that's an important point. That's another thing I hope to address in a future podcast with one of my lawyer friends, is patient rights when you're in the hospital. I know that has nothing to do with your question, but sometimes I go off on little tangents that need to be addressed. So, but you're doing the right thing with working with your hematologist on this one.
Max, let me know if that helps a little bit, and if not, we'll get back to you and hopefully help out some more. D-Lan, I see you. Thank you for letting us know. Keep us posted with how that's going. Let's get to, I'm going to put this up here from Tom. Thank you, Tom. Real quick, we did a video on Explain This with Robin Riddle, our nurse practitioner in the West Knoxville office, about lipid panels. I'm going to put it up for you guys to see. One, this is super interesting because we look at a lipid panel a tad bit differently than, say, a typical traditional medical practice would. Robin goes over everything in this video. I hope you guys will check it out. I think no matter what, like if you get a lipid panel done, go into it with this type of approach that Robin describes in that video. Thank you, Robin, for doing that for us. Let's go to questions here. Let's get to Wilma, and then I'll go back to Facebook. New article on the future of cancer treatment published September 19th, 2024 says use of ivermectin, fenbendazole, and fenbendazole protocol. What are your thoughts on this?
I use it every day on patients.
Yeah.
Yeah, I think it's great. Matter of fact, Andy saw a new patient today with metastatic prostate cancer to bone, liver, said every kind of chemo that they can do. And, what to do about it. Of course, we put him on a protocol. They say he has a few months to live, maybe a year at the most. Nothing's working. So why not try something outside the box? We do a lot of keto diets with this. We use a lot of IV vitamin C. So yeah, there's other things you can do. And I'm glad that you mentioned this because we've certainly been on this bandwagon for a long time. And you can go see some of my podcasts with Dr. Dan Bolton, a PhD chemist who treated his own esophageal cancer with Fenben and does a lot of, some patient support with it. And he's really, really good with that. Go to Fenben, some of our Fenben podcast. We've done at least 2. And, I'm starting to, of course, use concurrently ivermectin with it.
Wilma, definitely check out we've done a couple interviews with Dan Bolton that were received well. And if nothing else, it's super encouraging. And he's such a smart dude. Yeah. So thank you, Wilma, for putting that up there for us. I'm going to keep moving here. I'm going to go to Facebook, see if I'm missing anybody there. Let's see. Okay. There we go. I'm going to go to DPC. Thank you, DPC. Okay. And Wilma, let me know if that helped with your question. Asking for a friend, BPC 157, what to take to help with autoimmune PMR. What is the best way and time to take shots? How often? What else might you take for PMR? Polymyalgia rheumatica is what it is. That's a tough one. Yeah, that's a very painful condition. PMR is. I like BPC 157. I use it orally. Of course, for something like that, I'd probably take the shots. I'd probably do both the Sermorelin or Ipamorelin and BPC 157. I'd have to look up the dose for right now. It just doesn't come on the top of my head. But you mix it up. You have to get it from a reputable place, peptide place, which is getting harder to do. But you just take it daily. I kind of do it like I do the Ipamorelin 5 days a week. You don't need necessarily take it at night like you do the Ipamorelin or Sermorelin. But it certainly helps healing. A lot of times people will even mix BPC 157 and inject it right into a tendon or around the tendon. And it has some really good localized effects too when you inject it near the problem. But for that, you just do a sub-Q in your abdomen or anywhere really. But other things for polymyalgia rheumatica, which is an autoimmune disease, LDN would be my first choice to get on. Definitely get on LDN, low dose naltrexone. You can go to some of our podcasts on that. That's a major tool in our arsenal for anything that's autoimmune, whether it's Hashimoto's or PMR or rheumatoid arthritis, lupus, Sjogren's, all that. We use LDN and usually get good results from it. It's very safe. The only side effect I think I've ever seen or heard about is you may dream more than usual, which really means you get more REM sleep.
But some people don't like real vivid dreams. In that case, just take it in the morning, and it won't happen. But so try LDN, and there's all kinds of other things you can do for pain. I have that natural pain formula that's gone real well that I use. I have my own set of herbals I came up with in my pain formula, and people really like that. I take it daily. I have a lot of problems with low back, degenerative arthritis. It's really helped me a lot. I don't think I've reached for an Advil since I've been on it for a couple months. But so there's a lot of different avenues you can take. Certainly think outside the box. I don't know if your rheumatologist has mentioned some of the biologics, but certainly I'm not against them. Sometimes they help. I'm sure they've put you on some different stuff, but there is help for that. Sometimes you do have to think outside the box. And if you're not getting anywhere with your rheumatologist, you might want to come to a functional doctor like we have myself.
I'm going to put
medicine.
Roel up. What gauge needle for the BPC?
I just use an insulin needle.
Okay.
30, 31.
Yeah.
Smallest one you can get.
I'm going to put this up from Roel because this is referring to the list you put out for everything that you're doing, Doc. What progesterone, is it a pill?
Yeah, that's a pill.
Okay.
I take it because I want to balance out my estrogen levels. Because I take tea, you get a little aromatization, and of course zinc's another one that's very helpful for that. Some people take DIM, broccoli extract. But yeah, mine's a pill. You can certainly get a cream, but I like it because it's easy. I take it at night and it helps you sleep as well. And again, for men, I don't give them a very high dose like I do for the women. People think of it as a woman's hormone, but it's kind of like testosterone. Men need some progesterone too, and men need some estrogen. Look, we got a dog up here. Where do you come from?
What do you have to say about that? What do you have to say?
You take it? You take BPC 157?
That's
Purina.
That's Ike for those who don't know. What's up, Instagram? Kat, I see you. Okay, let's keep moving here. Patricia, what's up? Thank you for being here as always. What's your opinion on fulvic acid?
Yeah, I like it. It's a good binder. Certainly if you have gut problems, it's a good detox / binder. I sure took it when I had some COVID gut problems that bothered me for quite a while. And that was one of the things I really think helped bind some of it up. I like that. I like activated charcoal. But yeah, you're onto it. That's a really good supplement for your gut. And if you have gut problems, think about BPC 157 orally. It works really well. There's all kinds of things. Colostrum's a good one. There's a lot of binders that I think are really good for your gut, especially if you need to detox from, things that you come into contact with, be it from heavy metals or mold or any of that stuff. Yeah, great comment.
Thank you for that. I'm going to put this up again, a follow up from Patricia. Is that something you feel necessary to take daily, fulvic acid?
Yeah.
Mm-hmm. Okay. In the repertoire there. Thank you, Patricia, for putting that in. That's something we haven't talked a ton about. Mark, thank you so much for helping Max out. And Max did put a question there for the community. So if anybody can help him out, I'd appreciate it. Let's see. I'm going to put this up from Wilma. Thank you, Wilma. The mebendazole within that same family. Thank you so much.
Yeah, mebendazole is more the ones you think about being, it's one we use for pinworms in little kids, so it's very safe. It's really the more human form of an anti-parasite. Fenbendazole is originally, for animals, but the thing about it is mebendazole is unbelievably expensive, and Fenbid I think is just as good. So we like to use that because it's affordable and easily. You can get it over the counter. So that's what we prefer.
Thank you, Wilma, for that. I'm going to get to Mark. What's up, brother? AOD 9604 peptide for weight loss. It appears to work by mimicking the lipolytic fat breakdown effects of human growth hormone without the muscle building properties. Question is, See if I got you there. Stimulating for breakdown and inhibiting fat storage. Any thoughts on this? Maybe Mark has a little addition there.
Yeah, I've heard of it. I haven't used it for that, but it certainly seems promising. Again, a lot of these peptides, especially the more obscure ones, are hard to get a hold of, and that one's certainly not one of the more common ones. But yeah, I'm interested in maybe the fact that it may work. So we'll see. People think, what's a peptide? Insulin's a peptide. Of course, all the peptides that we use, like BPC, ipamorelin, sermorelin, well, it just means it's a chain of amino acids that cause an action somewhere else. So they've been fairly well studied, and people love peptides. Thank God for the peptide insulin.
Thank you, Mark, for that. I missed a comment from DPC. I'm going to get to that real quick. I want to say hello to Ernie. I see Ernie's in here over on Instagram.
Ernie's in here?
I did your mall walk today. It was
Ernie?
rainy and cold in Kingsport, and I took a mall walk. Thought of you. It was amazing.
It's refreshing.
Let's go to DPC. Dihydroberberine to take proactively for high cholesterol. Thinking to start with 100 milligrams once a day. Take AM or PM with food ?
Yeah, that's a good question. Dihydroberberine is certainly the one you want to take. It's 4 times more potent than berberine hydrochloride. Usually the dose is 200 milligrams, but I tell people prophylactically, if you're doing it for that, take it once a day. If you're actually treating high cholesterol, high blood pressure, of course, pre-diabetes or diabetes, then you take it twice a day. Mm-hmm. And I think you should time it 30 minutes before the biggest meal of the day. Or if you're taking it twice a day, 30 minutes before lunch and dinner. Those are the two things that I would tell you. But it's very effective. It really will lower those blood sugars. It's not going to be as potent as a statin for your cholesterol lowering, but it certainly has some positive things for it, and it's very well tolerated, and it helps blood pressures. It's just great for metabolic syndrome. Mm-hmm. To me, it's a no-brainer for people that have that metabolic syndrome of high cholesterol, high blood pressure, pre-diabetes, high waist circumference. That syndrome, we used to call it syndrome X, but now we call it metabolic syndrome.
That's interesting. I did not know it was called syndrome X.
It did.
Yeah. That's wild.
That's what they used to call it.
I see Ryan's in here. My brother over there. Ryan wants me in a game of tennis, and
he does.
Yeah, he thinks he can take me. And Ryan,
man,
I did a workout tonight. Tom, I want you to hear that. I did a workout tonight. I'm ready for you.
I don't think you can take him in tennis. I really got my doubts, but you probably do at a guitar playoff. You could definitely take him.
Okay, I'm seeing that I'm caught up on questions. If you guys have a question, go ahead and put it in the comments. We're going to be here for a little while longer. And if you don't, Motaz, what's going on, man?
In a while, have you?
We are. I'm at the same place. We're here in Kingsport.
Yeah, we're in the same place today.
So thank you, Motaz, for being with us tonight. Ivy, I see you. Oh, yes. We're going to get to that. Ivy, I see here. Sweet Tom. There we go. Okay, let's go to Ivy here. Ivy is saying, husband, 1 week post-op, L3, L4, L3-4 lumbar decompression infusion. Have him in T100 supervitamin, ASA. So I guess that's aspirin, 81 milligrams, high protein. Anything else, Dr. Recipe recovery? One, we're praying for your husband, Ivy, and thank you for putting this question in there.
That was a really, kind of an emergent thing he had to have.
Yeah.
Very, very painful. So I hope he's doing well, and I'm sure he will. I think the physical therapy aspect, as Ernie will tell you, is going to be very important. Certainly, testosterone is great for recovery. There's no doubt about it. You might even think about adding one of the peptides like sermorelin. That's a repair hormone. I would consider taking the pain formula as well, because that's all natural. I think that might help them. I'm trying to think of anything else besides a great diet and moving, getting outside, getting vitamin D. That helps recovery. Motion, high protein, high good fats. But I consider BPC 157. I think that would be really beneficial. Also, probably the injectable form. But if nothing else, try to do the oral form of it. I think that's really helpful too. Besides the GI effects, the great GI effects of it. But yeah, he should do fine. He's young. He's healthy. He's gonna do really well. I'm glad he's got that out of the way. I'm sorry it happened to him, but spines are tough.
Yeah, man.
Backs are tough.
Yeah, we were talking about that tonight.
Horrible. I had a bad back too, and I hadn't had to have surgery yet. I've had it suggested, but I really don't want to get surgery.
Yeah. Ivy, we're praying for your husband. Thank you so much for putting this in there, because one, I know a lot of people have very similar situations there, and I know that helps more than just you guys. So thank you so much, and prayers up for your husband. Let's get to let's see, one from Motaz. That's awesome, man. I'm happy for you. I hate that you're in the work until 8, but man, that's I hope you're doing well.
He's one of those high academics, PhD and college professor. I guess you're still a college professor. I know you had a bunch of options, but yeah, I mean, don't kill yourself working. You'll realize that someday, especially if you get my age. You'll say, hey, at the end of your life, I wish I just spent more time at the office. I don't think you're going to do that. So, set your limits, learn to say no, be efficient.
You know what? That's interesting that you're kind of going that direction. Is that was a part of the podcast episode.
I talked about it today.
Talked a little bit about one, your kind of philosophy around being honest with others, being able to say no, kind of protecting your time.
You've really got control over it yourself. A lot of times it's your own fault that you may think you have to work that hard, but really you may not have to. So don't, I know you have kids and also you want to spend time with them and enjoy your life.
Let's keep going here.
Thank you, Mo. Good job.
Thank you, Motaz. We'll just keep us posted, okay? Lisa, I see you. Yes, Lisa is right. Set boundaries. I love it. Roel is asking, when on testosterone, should we be on a baby aspirin? It seems like, they don't necessarily go together, but I'm assuming that you.
Yeah, one thing, that's a great comment. Yeah, number one, testosterone does not cause blood clots. That's a myth. Some of the cardiologists still think, oh, you're on testosterone, be careful. It's not going to cause blood clots. You should be on a baby aspirin anyway. In my opinion, at a certain age. Certainly, I started at 40. I'm basically 70, almost 70. So I've been taking one for 30 years, and I will take one until I'm so frail and demented, I'll fall and hit my head and bleed out. Maybe that'd be a good way to go. Say 100 years old, you just conk your head, you bleed out in a few seconds, and that'll be the end of it.
Roel, I wasn't expecting him to take it that direction.
Don't be afraid of aspirin.
That is
unless you have a peptic ulcer or a bleeding disorder or something, but be afraid not to take an aspirin. And put that in your travel kit too.
No, be on I'm 38. I'll be 40 in 2 years. Should I start taking it at 40, you think?
I think you should start taking it now. Based on your fitness level right now, I think I'd go ahead and start.
Oh goodness, he was watching me work out.
You look like you just got out of jail or something, or a mental institution.
I got. It's the hair. I've got to get a haircut. Okay. Let's see. I know I see Mark's question around. I'll get to that. There we go. AOD 9604 is one of the peptides when injected has been shown to have very favorable cartilage repair and regenerative properties, especially when paired with peptide BPC 157. or hyaluronic acid? Is this something PM may look into in the future?
Sure. Well, consider all the peptides. There's a lot of them out there. Alpha and beta thymosin. There's a ton of them out there. MK77, I think. You gotta be careful with that one. So yeah, I mean, there's a lot of different ones out there that are probably pretty good. I tend to go with the ones that have been used the most and for the longest. So, that I'm very comfortable with. I'm never like to be the first one to try something new or, that hasn't been pretty used.
That's something I'm not sure people, especially, people who are watching tonight, like, for all the things you do, you're hesitant to start new
I'm
things.
very conservative.
You're very conservative. If you guys look at the article after the show, it's the article on the website is performancemedicine.net, and it's titled "How I Personally Biohacked My Longevity." So it's the most recent blog post, and there's a lot on there. But people would think, oh, he just tries a ton of different stuff.
Yeah.
But you're pretty conservative.
Yeah, I'm definitely conservative.
it's
I'm scared of medicines, But yeah, I mean, I am. But you look at my vitamin list; it's pretty extensive. Although a lot of them are combination vitamins. I've synced it down a lot since we're making or having our own vitamins made out in Oregon with no fillers.
I agree with Tom here. I hope.
Thank you.
Yeah,
Thank you,
that's
Tom.
awesome. That's awesome. Thank you, Tom. Thank you for watching.
I hope I do too, as long as my health span is good and I'm with it and healthy. I certainly don't want to, be unhealthy and a burden or in pain all the time or not knowing where I am. I don't want that. So
yeah,
I think about brain health a lot too.
Which we're going to do a podcast this week on brain health with Dr.
That's
Pardue.
right. I can't wait for that one.
Really excited.
That's going to be a great one.
Okay, let's get to DPC. Some time ago, Doc made a comment regarding not to get a root canal. My question is why and what other options should be considered? We've done a couple of podcasts with Dennis. What's your thoughts on this?
Yeah, you should avoid it if you can because of infection and seeding. Again, sometimes you may have to get a root canal. But if it's just past the point where that nerve is just damaged, you have abscess and all that. Again, I'm not a dentist. I need to get back on there with Dr. Creech.
Yep.
Actually, I'm going to go out to her office and do a podcast on different types of oral cancer and how to screen for it and prevent it. So I'll go over that again with her. Certainly, sometimes you may have to have one, but just do your research on.
Do you think people get root canals that don't need one?
Yeah, I think people get a lot of medical procedures they don't need.
Sure.
I do. I really do.
That is that whole the one on fluoride with Dr. Creech was fascinating. The whole thing. There's been a couple videos with Dr. Creech that have been really, really fun.
Yeah.
Huge shout out to Dr. Susan Creech.
Sometimes antibiotics help. I even Dr. McCary, who's a surgeon at Hopkins, he was talking about something very interesting in that, and it kind of relates to this cognitive dissonance that doctors just do things the way they've always done it. But you can actually treat an early acute appendicitis with antibiotics and not even have to take the appendix out.
You know what? I think I heard about that.
That's what Fran decided to do with her son. It worked great.
Really?
Yeah, but that's like heresy in the surgical, among the surgical fields. Of course, my dad and my brother, they take it out. But yeah, I mean, we've learned a lot of new stuff, and if you catch it early and all, you can treat it with antibiotics.
I like that. To me,
read the book Blind Spots. This is coming from a general surgeon.
Blind Spots. Is that Roel? Did Roel recommend that book? Who recommended Blind Spots? I believe it was Roel.
It might have been.
Yeah, and you've been doing a deep dive on it.
I like that book.
Yeah, I think for me, like when I hear you say that, that's exciting to me. There's so many different options now, and I think that's how we need to look at what's happening in integrated medicine.
One of the main things he talked about, and this is a general surgeon at Johns Hopkins, was the misinformation about bioidentical hormone replacement for women, how it denied a whole generation of women from these incredible hormones that they said it caused breast cancer. It does not cause breast cancer. So yeah, there's a lot of things. It's hard to really change medical opinions, even despite enormous new research that shows they were wrong. But I think doctors have a hard time admitting they're wrong and changing their practice ways.
Sure.
Because it's too hard for them. They're seeing too many patients. This is the way they did it in the residency. Here you go. This is what we do.
Sure.
This is how we do it, which is a real disservice.
Yeah.
It just goes to I'll start preaching, but it goes to the way medicine's been corporized and cookbooked. And, it's a little more, it's a little bit more difficult than that. You actually have to listen to your patients and talk to them and consider options. And, in the end, the patient always should make the decision, unless it's a patient that can't make a decision.
Yeah.
An informed decision. And I think that's something that I'll talk about with the healthcare lawyer. That's very important.
I'm super excited about that episode. And, one other thing, we talk a lot about hormones on this show and, in all of our content. And, there is a lot of questions about cancer. And I think I told you today that we need to do an episode on or hormone therapy and cancer, because there seems to be this mentality that hormone therapy is related somehow to cancer, breast cancer for women, prostate cancer for men.
Yeah, and it's actually the opposite. Estrogen does not cause breast cancer. Testosterone does not cause prostate cancer. If anything, it's favorable to prevention. Mm-hmm. So
we need to do a dedicated podcast on that.
Yeah, I think we have. We put so much information out there, but we'll put more.
Yeah,
because people really need it.
I'm gonna put this. Okay, I'm gonna put Linda's up, and then I'm gonna get to Fred. I see Fred over there in Texas. I'm gonna get you up here, and I'll get Wayne as well, because I agree, Wayne. I think a lot of us can be overwhelmed by the amount of supplements we think we should be taking. So we want to address that. Do you have problems with synthetic hormones? It's a great question. What's your thoughts?
In general, I certainly wouldn't use synthetic hormones on women for sure. Sometimes there's a fine line between what's synthetic and what's natural. The bioidentical hormones they come from plants. They're made from yams most of the time, and it's just safer, in my opinion. I don't like, for example, progesterone is a completely different compound than medroxyprogesterone. Bioidentical progesterone, if you look at the chemical structure, it's completely different than medroxyprogesterone. The same thing that's in birth control pills or Depo-Provera. They're not good for you. So but they're good for birth control. But I'm not saying they don't have their place, but certainly with women, I don't use synthetic hormones. When you go to the pharmacy, you can get Prometrium, which is a bioidentical hormone. The difference there between the Prometrium you can get at CVS and the progesterone you get at a compounding pharmacy is at the CVS, Prometrium is mixed with peanut oil. So if you have a problem with that, I prefer not, but it's still a natural progesterone. It's not medroxyprogesterone, which was the bad boy in the Women's Health Initiative. That's what caused all the controversy. It really wasn't even estrogen. The women on estrogen compared to women without estrogen had less breast cancer. Mm-hmm. That even Premarin, and that was Premarin, a pregnant horse urine estrogen. They even had less breast cancer than the women that didn't take anything. Less. The one thing that they got this from, which is totally erroneous, but there was the incidence of breast cancer using medroxyprogesterone, which we never use. But a lot of doctors do because they don't know the difference. The incidence of breast cancer using Prempro, which had the horse urine estrogen, which turned out to be all right. We've got much better, but the medroxyprogesterone combination, when they used that medroxyprogesterone, the incidence of breast cancer went from 4 women per 1,000 to 5 women per 1,000.
Mm.
And somehow they termed that a 25% increase in breast cancer with hormones. So it really was a screwed up evaluation. Even if you look at the reanalysis of it now, they'll just say, because they hate to admit defeat. Look at Dr. McCarty's book, Blind Spots. I mean, he's as qualified as anybody to talk about this.
Yeah.
He's done more research, medical research, and published papers than almost anybody in the world. And he's at Hopkins. But in any event, he called that the greatest injustice for women in the last, 30, 40 years. So it was really a total sham. There was a lot of other confounders that were just ridiculous with that study. But anyway, if they on the reanalysis of that WHI study back in 01 or 02, I think, they've said, it's the decision to use hormones that should be between the patient and the doctor. So that's all I say. It's hard to admit when you're wrong. It's just hard to say, but it's ridiculous. Man, a whole generation of doctors have been misled. It's really not the doctor's fault. They're ingrained in this stuff, and they're so busy they don't have time. They just have to take the word of a drug rep, or their internal medicine association has been doing the same thing for 40 years or 50 years. Same thing with the American Association of OBGYN, American Academy of Family Practice. They're just slow to change and look at new evidence and to consider things. So it's a shame, but yeah, I don't have a problem. I'd rather use bioidentical.
Linda, I hope that helps. Thank you for teeing us up on that topic. We think it's a very important topic. Roel, thank you so much. I love you back. Let's get to Fred here. Family member that started with shingles. She's taking AFib med metoprolol, 25 milligrams, and they also gave her acyclovir, 80 milligrams for the shingles. Also takes carbidopa, levodopa for Parkinson's. Do they mix okay? She had vitals that were low, like heart rate, blood pressure. Went to eat last night and told her to get off of AFib med, I believe, Fred. She went to the ER last night. Okay.
Oh, yes. Put the first part there. Yeah. Of course, she's on metoprolol for AFib. The acyclovir is, of course, for the shingles. That shouldn't interfere with the Parkinson's medicine. A lot of times too, for shingles, I usually add a Midral dose pack in there. I think it's very helpful. I think it's a short period of treatment for a week, but it's probably going to prevent post-herpetic neuralgia or neuropathy. So definitely treat it aggressively. Metoprolol, it's a very small dose. I mean, you need to make sure that they're hydrated and all the electrolytes look good. I'm sure they check those in the emergency room. But the metoprolol, depending on heart rate, if her heart rate's really, really low, you'd hold off on the metoprolol. And I assume that she's back in a normal sinus rhythm, but maybe she has chronic AFib. If she does, she needs to be on a blood thinner, because that's the most dangerous thing about AFib is throwing a clot, getting a PE from it. But certainly that's a patient that needs to have guidance from the doctor that knows everything about all this stuff. Mm-hmm. Not just your Parkinson's doctor may not know how to treat AFib. That's one problem in medicine now, is that there's just not enough good primary care doctors that can put all this together. You've got your cardiologist for your AFib, you've got your rheumatologist or for your arthritis, you've got your neurologist for your Parkinson's, you've got shingles, infectious disease. Maybe, hopefully, your family doctor or internist is a good one to put all that together and monitor things. But certainly keep an eye, make sure that she's hydrated.
Fred, keep us posted. Thank you so much for putting that in there. We'll be thinking about your family member, but thank you so much for being with us tonight, as always, man. Let's get to, I want to get to Danny. Then I see Mark's got a good one. And I want to talk about the Wayne one as well. What's your opinion on the carnivore diet with helping with
I like it.
inflammation.
I like it. I know it's controversial. Um, I like the carnivore diet. Again, there's various opinions. I was reading Mercola today, and he thinks that carbs have been demonized too much. Maybe so. I mean, it's hard to live without some carbs. Even Salandino, who wrote the Carnivore Code, eats fruit, certain fruits with, his meat. So, yeah, I like the carnivore diet. When I had that post-COVID bad gut, the carnivore diet really helped me a lot. But along with some other things that I threw in there and helped me a lot. But inflammation, I think, is great if you look at an autoimmune diet, even look at Gundry's. I mean, his is mostly following along the carnivore diet, because a lot of these things that are in plants, even though you hear plant is the best blue zone type of diet, it's a lot, and it may be there's certain people that can do it, but it depends on their gut microbiome. And certainly, but with Gundry's, I mean, it's basically pretty much a carnivore diet. Because, for example, vegetables, there's a lot of, and grains, whole grains, he cuts them out entirely because there's a lot of inflammatory things in glutens and lectins you get from plants as well, especially in beans. Beans, it turns out, has one of the highest glycemic indexes of anything.
Really?
More so than pasta, I think.
Really?
So yeah, I never knew that, but I was comparing them in a list the other day. But
Black beans,
so
just beans in general.
Beans, yeah. So there's a reason beans give you gas, because they're very hard for you to digest. They have lectins. These plants don't want to be eaten by animals, so they have these proteins called lectins that make you sick when you eat them. So the same thing with whole grains. I mean, we've been taught to eat a whole grain diet our whole life. Cereal, wheat, all that stuff. And it turns out it's not great. It's inflammatory. So yeah, I do like the carnivore diet. You may play around with it a little bit. Everybody's a little bit different.
I'll give a huge shout out to Digestio, which helps with those lectins.
I was just about to say that.
Yeah. Let's keep moving here, guys. I see, let's get to this question from Mark. Recent studies indicate the biological changes in microbiome at ages 40, 60, 80 contributes heavily in aging. Any thoughts on this treatment, on this being a treatment for longevity in the future? So I'm assuming treating the microbiome at these ages. Is that am I reading that right, Mark?
Yeah.
Does that sound right to you?
Yeah, there's
Okay.
no doubt about it. Your microbiome tells your brain what to do. Certainly, if you have more of the bad bacteria, you're going to get demented a lot easier. So, I think it comes into play. Everybody needs to be looking at it now, and that's why we do a lot of GI maps and things. We look into gut, especially with autoimmune diseases, and if you can correct the microbiome, then you're one step ahead with everything.
Real quick, this is going to be the last question here. Then we're going to call it a show. Wayne is talking about just being overwhelmed with, the amount of supplements that we all feel maybe we should be taking.
I wouldn't, take the major ones for sure. If you look on my list, it may overwhelm you. But again, a lot of those are in the same pill. That's why I got that company to kind of combine all these things. But don't get overwhelmed. I consider supplements and vitamins part of my nutrition. But always look at D with K, aspirin, unless you have a contraindication, omegas, certainly magnesium, take the right form at night, and a good multi, that has a lot of that stuff in it, because you really do need them. So if you got a good multi that had to do, look at my super vitamin. I mean, I think it's the best vitamin I've ever seen. I made it specifically for that. Take it with food because it's potent, and we don't have to take so many if you take the super, because you're getting all the stuff in it. You're not getting omegas. You need to take those separately. And the magnesium, no, you take that separately at night.
Your
I
thoughts,
think he wants to.
your thoughts on that? Your thoughts?
Do you take a vitamin? You like to eat that, would you?
I want to clear this up for Linda. That's a great question. Then we're going to call it an evening. Did you say medroxyprogesterone 2.5 was bad?
Yes. Yeah. Do not
Okay.
use medroxyprogesterone.
Taking one
If
every
you-
other day for over 30 years and Premarin 0.3 every day
Yeah,
as well.
just get off of those. Look at bioidentical hormones.
Mm.
Yeah, I don't like that combination. Look at bioidentical hormones. Please do your research on that. Read Dr. Pam Smith's book on it. You can order it off Amazon. It's a great book on educating you about what bioidentical hormones, and then you give your doctor a copy of it, or find a doctor that's willing to give you bioidentical hormones, please.
I see Robin's in here. Robin, thank you so much for helping Linda out. And we've got a couple different videos with Robin on Explain This on the YouTube channel, talking about hormone therapy for women, bioidenticals, the difference between that and synthetic. So thank you so much, Robin. Okay, guys, how'd we do? New setup here. What's up, Instagram? I'm going to close out the podcast, and then we are going to end this show. Pop Man, thank you so much.
Let's click microphones. Good job. Good job.
Is that like click doing a fist bump?
Or drop microphone. I think you did so good. I just dropped the microphone. I don't want to bust it.
Guys, we love you so much. Thank y'all for being with us every single Tuesday. We do this show every single week, 7 to 8. Sometimes we go a little bit over. We love hanging out with y'all. So please come back. We'll be back next week. Instagram, we love you too. Thank you guys so much. Which hour? I see you. Thank you back. We do this every week. So come hang out with us next week. Performance Weekly comes out on Tuesdays as well. You can subscribe to that email newsletter on our website, and all the vitamins we've mentioned you can find on performancemedicine.net. We love you. I'm going to hang up here if I can figure out my thank you, Grandma Mary. I love you. If I can figure out my outro, then we will call it a show. Pop Man, thank you so much.
You're good. Thank
This
you.
was fun. Are we going to go eat
I'm
now?
glad you're here.
We're going to eat.
I've already eaten. You can eat. now.
We're going to eat. Maybe watch
I have
a.
to eat early. I don't eat late at night.
That's right.
I do the intermittent fasting.
I'm not intermittent fasting tonight. We'll watch a movie or something. We'll have us an evening. All right, where's our outro? And there we go. And I'm gonna boom.
Don't go away.
Oh, we're still live. What? There we go. Hey guys.